We have completed the use of what is evidence, the levels of evidence, and the use of tools. Now we'll come to individual scenarios. RCTs are considered the highest form of research when you're considering the effectiveness of a treatment or the efficacy of a treatment. So we'll talk about critical appraisals of RCTs first, randomized controlled or randomized clinical trials. Just briefly to introduce the topic, when is the design used? When is a randomized RCT used? RCTs are used to study advantage of one treatment modality over another. Purpose of this design is to minimize bias to the extent possible because the participants are randomized into groups where there is no allocation bias. The important aspects are all in the name. There should be randomization, there should be a control or a comparison group. What is randomization? There are many methods of randomization. The most highly rated one is by producing a random numbers table from the computer generated random numbers table. Other methods are also used. The more stringent the randomization method, the better. But there must be a pragmatic component. If not, the study cannot be done. So the stronger the level of randomization, it might make it difficult to get patients. So you need to decide on the randomization process. Every participation, but the bottom line is every participant must have equal chances of being in either of the arms of the study, or if there are more than two arms, in any of the arms of the study. If the measurement has a subjective component, like in rehabilitation and nursing, measurement must be done by someone other than the researcher. This is called outcome measure blinding. Other blinding will be treatment blinding, allocation, concealment, and so on. Allocation into groups must be done by someone who does not know the study, like a receptionist or a student. That's called allocation concealment. In drug trials, even the researcher will not be able to know which drug the patient is getting because they are unmarked drugs, and only the pharmacist who is supplying the drug will know which it is. So this can go up to the level of quadruple blinding. But this is not possible whenever there is a subjective component involved, like in rehabilitation, nursing, counseling, and so on. Also in surgery. Now, if there is greater level of blinding, then there is greater power. But if that is not possible, the power of the study will automatically decrease. Another thing that you must consider is participant attrition through the trial. So they may have recruited n number of participants, but by the time the trial is over, especially if it is long drawn out trials, there will naturally be an attrition. Some groups may have greater attrition than the other. So if the groups are not equal at baseline and equal at end of the trial, then the results become somewhat non-applicable. Also, there's a large number of attrition. What large amount of attrition? What measures were taken to control for this attrition is something that must be reported. So when you critically analyze a RCT, you must look for these components. Basically, though, parts of an RCT are again PICO: participant, intervention, comparison, and outcome. Participant or patient, you want to look at whether the two groups are comparable in baseline characteristics, including things that may not be actually measurable, like age, gender. The effect may not be measurable. Diagnostic level, if they're looking at a particular disease where the participants in both groups equally distributed at different levels, acute, chronic, or stages of the disease, or baseline characteristics of diagnosis, these are the things you need to look at for baseline comparison. If one group is unequal at baseline itself, so there is this that is a statistical thing where people who do poorly at the beginning are likely to improve the most, and those who do very well may decrease in their outcome. So this should not be. So both groups must be equal. Were the numbers comparable? It need not be 22 and 22. There can be slight differences, but they must be comparable. Were the numbers sufficient for statistical power? How did they calculate the sample size, and what was the power that they considered while calculating the sample size? Otherwise, we know that the power of the study is not adequate for extrapolation. Were the participants recruited through transparent processes and allocated randomly? These are the questions you must keep in mind when you're looking at the participant or patient criteria. When you come to intervention, was the intervention theoretically sound? That is a judgment call, for which you need background knowledge. Was this intervention worth researching at all? Was the intervention blinded? If blinding is not possible, what measures were taken to minimize bias? Was the interaction time between patient and clinician equal across groups? Because there is an effect of interaction with a clinician. So if one group had 1 hour of contact time and another group was contacted only through the telephone, there is a chance that the group that actually saw the doctor or the clinician may do better. Were there any adverse effects reported? Coming to C, was there a true control? A true control is where no treatment was given. If this was not ethically possible, then was the comparison group a true comparison? Was there any likelihood of contamination between the two groups? And if they said that the comparison group was routine, traditional, common management, then the details of this routine, traditional, common given, because these things, routine management was given to the comparison group. This is a common line that we read. Now, we do not know what that particular country or that particular institution's routine is. So, unless that has been cited or unless that has been described, we have no ability to compare. Coming to O, were the outcome measures robust, relevant? If the outcome is a subjective tool, were the psychometrics of the tool ascertained and reported? Was any modification done to the tool? If so, were psychometrics ascertained again? That should be any, not nay. Sorry for the typo. This is important if clinical messages are given as a result of the study. If they say that this is a good method of treating patients, then these things are relevant. The outcome measure is relevant. If the only conclusion is that one group fared better than the other and both were administered the same outcome measure and no group differences are expected, this might not be such a serious concern. So if you're saying this is better than another, then even if the outcome measures were, the psychometrics were not ascertained to a great extent, it may be acceptable. But if they're saying this is a good thing to do, a definitive statement like that, then you have to know about the outcome measures robustness. Were the measurements administered at logical and relevant intervals? This also we need to know. The one common pitfall here is quality of life measures. Quality of life measures are sometimes given at the beginning of a trial and 6 weeks after a trial. You cannot really do this because quality of life is influenced by many factors other than just the disease. So what if something in their personal lives have changed, or what if there is climatic conditions? What if the trial started in spring and ended in winter? So maybe if they are not able to deal with the cold, they might have had, their quality of life might have been lower, because there are things that affect quality of life other than what you're studying. So these are things you need to just keep in the back of your mind. It's not highly important, but it is something that you need to think about. Now, how do you appraise RCTs? The tools are meant to guide. You have to know enough research and clinical knowledge. You have to know enough about the subject to make judgment, because finally tools are meant to guide. Appraisal is judgment, and you need to have adequate knowledge about research. Tools help to focus on the important aspects and minimize the halo or horn effects, as I had talked about in the last class. So let's come with one of the older tools, the Jadad scale. It was described in '96. It's very simple, very short. The points are awarded based on, is the study randomized? If yes, you give 1 point. Is the randomization procedure appropriate and reported in the study? If the answer is yes, you give 1 more point. If the answer is no, you remove the point given for the first, is the study randomized? So then the first question will get 0. Is the study double blind? If the answer is yes, you get 1 point. Is the double blinding method appropriate and reported in the study? If answer is yes, you get 1 point. If no, you delete all points for the second question. Are the reasons for patient withdrawals and dropouts described for each treatment group? If yes, you get 1 point. And if the study earns 2 points, it's considered to be adequate. Okay. Now, I'll give you an example. This is a 2-arm RCT that was performed somewhere in Turin University. It's a 2-group design. This is what the article says. This is a 2-group design. Subjects were randomly assigned to the experimental and control groups. So for question number 1, the first part, you would say 1. Both groups attended lessons in the classroom. Well, that is okay. So it says they were randomly assigned. How they were assigned, the randomization process says participants were randomized by a computer-generated randomization scheme and the identification number from the randomized allocation schedule. So for question number 1, this article would get 2 points. Question number 2 about blinding. What is highlighted in blue, it says students were assessed individually by a blinded evaluator using observational rating scales. So going back to the question, is the study double blind? No. It is only single blinded. And actually in the study you cannot have double blinding, because it is the students will know what kind of intervention they are getting, because one intervention was instruction and the another intervention was video. Naturally they would know. So on Jadad they've got 1 point. Question number 3, that is what happened. Are the reasons for patient withdrawals and dropouts described? There were no withdrawals. Okay, so here all 223 joined and 223 completed the study. So for question number 3, they get 1 point. So on Jadad, the study will get 3 out of 5, which means it is a good study. The main focus of Jadad is blinding and randomization. It may be inappropriate for studies where blinding is not possible and outcomes are not objective. It's very simple to use and it is easy to interpret because interpretation guidelines are given. Another tool is the CASP, that is Critical Appraisal Skills Program. In that you have tools for different types of studies. Section A, so CASP RCT, checklist. These are checklists, not, there are no numbers on it. I mean, there is no minimum number. So the first question on CASP RCT, there are 3 sections, section A, B and C. Section A, the first question is, did the trial address a clearly focused issue? Yes, no or can't tell. This is the same study, the nursing study. The introduction says, access to the web allows the scientific community to acknowledge and promote exchange of opinions, etc. Nursing education is considered by many to be a pioneer in the use of educational technologies. A challenge is the use of emerging technologies, which will help to bridge the gap between the next generation and faculty in nursing schools. Nurse educators need to understand and use the power of technologies to prepare the next generation of nurses. Goes on to say, some authors are concerned about the risk that the use of computers will belittle rather than to improve education. They argue whether the use of technology will ever be able to replace the fundamental role of the teacher in student learning. So the question is adequately debated. For and against is given. So did it address a clearly focused issue? Yes, it did address a clearly focused issue. The second question on section A is, was the assignment of patients to treatments randomized? Yes, in this case not patients, participants. Were all of the participants who entered the trial properly accounted for at its conclusion? Yes. Were the groups similar at the start of the trial? The table 1 in the article says characteristics of the study sample, experimental group and control group, and the p-value is not significant. So that means they were similar at the start of the trial. Aside from the experimental intervention, were the groups treated equally? Both, it is not adequately mentioned, except there is a line that says both groups attended lessons in the classroom as well as in the laboratory. A month later, they went through the study. So we cannot tell. We do not know if they had access to the hospital clinical rotations, whether they were working elsewhere, because as you can see from the table, other degree yes no and CNA yes no. So there was slight difference, 9 and 12 and 3 and 2. So if they were already a certified nursing assistant, they may have been working elsewhere. So we are not able to tell if the groups were treated equally. Were they prevented from working during the this 1 month? All that we don't know. So I would give this question can't tell. Now we come to section B. How large was the treatment effect? What the authors say is the mean difference observed between those participants who had seen the video and those who had read about the technique was 6.19 points. This is on their weighted score of a questionnaire that the university had developed. So we don't know really how large was the treatment effect, because we do not know what is the effect size of this questionnaire. How precise was the estimate of the treatment effect? Here again we run into trouble. Assessment was done by a questionnaire prepared by the research team, which according to the study was pilot tested. However, details of this are missing. Can the results be applied? So what I would say is, how precise, can't tell. Can the results be applied in your context? Due to the potential shortcomings of the outcome, it is based on judgment. We don't know what the questionnaire was, so I would say no. Can the results be applied in your context? I would say no. Were all clinically important outcomes considered? Other than the one test, carry over into clinical situations is not mentioned. So I would say that it is no. Are the benefits worth the harms and costs? Again, I would have to say no, because we do not know whether there was any carryover into, whether they checked any carryover into clinical situation. We do not know about the characteristics of the questionnaire, and we do not know about some of the extra information that participants may have had during the 1 month of study. So it would either be can't tell or no. Now, what does CASP do? On JADAD, the article scored good. On CASP, it is opening up a lot of unreported things. So it tends to give you a question. If you used only JADAD on that article, you would say it's a good study, and you would probably use the same methodology for your students. But when you critically analyze it, appraise it using CASP, you get many more questions, and then you wonder, is this a good study or not? Because as we saw, can the results be applied in your context? No. So then you would say, oh, maybe it works in Turin, but it did not. But it definitely doesn't work for the nursing education at large. So what does CASP do? What does JADAD do? JADAD talks about blinding and randomization. It talks about allocation bias. It talks about that. whereas CASP is talking about internal and external validity, statistical validity, everything. CASP was, if you will go through the website, you will understand that it was made for a workshop, so it does not have a score. It is just a checklist. It is giving you guidelines and it depends on your judgment. Now you have the consort checklist. Consort checklist is even more elaborate than the CASP checklist. It has internal validity, external validity, it has ethics, and it has reporting. So it starts with questions on title and abstract, presentation, trial registration, etc. So we go back to this same article that we were talking about. So the question here is, the title here is Effectiveness of an Educational Video as an Instrument to Refresh and Reinforce the Learning of a Nursing Technique, a Randomized Control Trial. On the face of it, it's a good elaborate title, a descriptive title. But when you look at the definition of effectiveness from a statistical point of view or a research point of view, effectiveness trials are supposed to be pragmatic trials. Pragmatic, where they are practically useful. And they measure the degree of the beneficial effect under real-world clinical settings. Efficacy trials are explanatory trials which determine whether an intervention produces the expected result under ideal standardized circumstances. As you know, the study that we were talking about is an efficacy trial. It determined whether the intervention of an educational modality produced a change under a standard circumstance, not in real world, or if they did, it was not mentioned. Real world clinical settings was not mentioned. So what happens here in consort when we go? The title itself is erroneous, or the title itself is open to question. So there are many more. The consort checklist is quite very elaborate. So then there are other things like conflict of interest and so on. Now, at the end of this study, the authors have written, the aim of the study is to verify the effectiveness of the video as an instrument for refreshing and reinforcing nursing education. As we discussed, effectiveness is a wrong choice of terminology. And there is one sentence there. The universities need to provide a useful tool for students. Could this be a conflict of interest? It's up to you to decide. So bottom line, when you're critically appraising RCTs, there are many more tools, but I have just taken 3. One is JADAD, which came out in 1996. So for 1996, it was good. Focuses on, but thing is, it is still used. Focuses on research methods. It talks about the human factors. CASP focuses on research methods. The CASP checklist focuses on research methods, statistical methods, and applicability. The consort checklist focuses on other aspects of research as well, including reporting ethics and presentation. Depending on your purpose, use the tool of your choice. Novices should probably start with JADAD. Once you learn statistics, move on to CASP and consort, because you require knowledge to be able to appraise whether the theoretical constructs were appropriate, whether the statistics used was appropriate, and you should also know terminology, as we noticed, effectiveness and efficacy. If you are using the tool on your study to attempt publication in a reputed journal, appraise your own article using the consort checklist so that you don't run into trouble, and so that you know that you have made all the appropriate corrections or done the statistics before the appropriate statistics before you even undertake the study. So when you plan a study, you must look at the consort checklist and decide, this is how I'm going to plan my study. That would be the best way to do it. Thank you. Just one thing I forgot. Please appraise the same article. The article that I talked about. using each of the tools to get a feel for the differences. And this is the article. Thank you.